Greg, thank you so much for those remarks. At this time, we're going to move to our panel discussion, and I invite Susan Dentzer, and our distinguished panel up to the audience. Please, if you will. I think most of you know Susan. She is the Senior Policy Fellow at the Duke Margolis Center for Health Policy here in town. Susan was previously president and CEO of the Network for Excellence in Health Innovation. She served as editor-in-chief of the Policy Journal Health Affairs previously and was an award-winning on-air health correspondent for the PBS NewsHour for a decade. She's a long-time healthcare policy expert, and she'll be doing formal introductions of the panel. I just want to say for our panelists, particularly Carolyn, who's been a friend and mentor of mine since I started at Health and Human Services back in 2005. Great to have her back at BPC. And Jerry from Geisinger Health System. We have a health system executive council here at BPC, leading health systems across the country who advise us, so we know what's happening on the ground, and Geisinger has been a great addition to that council. And then also having health partners here, another leading health system, has been terrific. So we have a great panel here, so I'll let Susan take it away. Thank you.
Terrific. Thank you, Anand. Good morning, everybody. It is terrific to be here with you. And I think it would be appropriate before we plunge into our panel just to recap some of the really important themes we've heard in these fantastic presentations of the morning. First of all, as we heard from Katie, this is all about medication optimization. And what we have in this country today is anything but medication optimization. Witness the estimate of $530 billion a year in waste and harm that accrues to patients because of lack of medication optimization. And take note, 275,000 estimated deaths as a consequence of that. So this is big. If you think back to the famous report Crossing the Quality Chasm in 2001 of the then Institute of Medicine, and what the Institute of Medicine said at the time are the hallmarks of a better system, that it should be safe, that it should be efficient, that it should be patient-centered, that it should be timely and efficient and equitable. The fact that we don't have medication optimization fails on all of those counts. It's not safe, it's harmful, it's not effective. We heard Brenda Shipley's story about mixing up medications and what resulted in her mother having an unnecessary hospital stay, and not just one. It's clearly not patient-centered, it's not person-centered, it's not even caregiver-centered. It's clearly not timely, it's not efficient, and we don't have statistics about how unequitable or inequitable it is, but we can bet it is, right? We can bet that the people who are most disadvantaged in the healthcare system generally are probably harmed even worse than anybody else from this lack of medication optimization. So we heard from Katie about the strategy of getting to comprehensive medication management. We heard about the tactics that will be necessary to get there, whether it's information technology, whether it's better diagnostics. We heard that just very powerfully now, restated again by Greg. We heard about the need for interprofessional teams that integrate medication experts, and how far we are from on multiple scores from that. And then, as we heard from Liz, this is apparently going to be such a powerful strategy that we need to develop the evidence, better evidence that it really works. And that is going to be, whether it's randomized controlled trials or whatever, policymakers are going to need the evidence to develop the kinds of policy initiatives that Greg, in effect, was calling for. So now we go to this panel to talk about what is happening in the here, in the now, and how we can, how you all are marshaling these various tactics to get to this goal that we're all seeking, and what else needs to be done about it. So to say a little bit more about the people that Anand briefly introduced, Carolyn Clancy here is a physician. She is Deputy Undersecretary for Discovery, Education, and Affiliate Networks at the Veterans Health Administration. Jerry Greskovic, who is with us here, is the System Director for the Ambulatory Program, correct, at Geisinger, of course based in central Pennsylvania, but with a almost an interplanetary reputation now as a leading
Way to put the pressure on me.
as a leading health system. And then Dan Rauer, who is a pharmacist. He's the senior manager of medication therapy management program at Health Partners in Minnesota, with maybe a national reputation, if not, I'm sure interplanetary is right around the corner for Health Partners, a really distinguished integrated system based in Minnesota. So we're going to start out with just a few minutes of overview as all of these folks tell us what their systems are doing in this vein. And Carolyn, we're going to start with you.
Sure. Thank you, and good morning, everyone. It is really a pleasure to be here. I will tell you, as the only physician in a very large extended family, I hear about all medical problems on a regular basis, some of which are quite serious, some of which are all about exactly why don't we have physical therapy on Friday nights and so forth. But medication management gives me nightmares. So the really great news in 2020 is how infrequently we need to have people hospitalized anymore, which is fabulous, right? We can manage so much as outpatients. The slightly less good news is we have not really planned the infrastructure needed, as Dr. Downing would say, to make that work as well as possible. So I can tell you, in the spirit of healthcare being a team sport, we couldn't serve the nation's 9.2 million veterans who are enrolled in our system as well as we do without a fully robust team, including pharmacists. So getting the medication right is important, and it is doable. And I'm going to guess my colleagues will echo that theme as well. Just so a little bit about VA, VHA, or the Veterans Health Administration, is probably the largest healthcare system in the country. Now, I do note in lots of conversations about mergers and acquisitions, everyone keeps saying, no, I'm bigger, mine's bigger, and so forth, but it's large. So we have over 1,200 points of care, including 170 medical centers and many, many outpatient clinics and the like, and we've got skilled nursing and nursing homes, which we call community living centers, and on and on. And we provide a fair amount of care to patients at home and in other settings. And just to make it really challenging, almost 80% of the veterans we serve have other insurance. Now, until recently, and probably still, Medicare would be the most common other insurance. So by definition, we've got people who are getting some care over here and some care over there and so forth. And we are a very, very important actor in having an impact on future healthcare professionals. So for 75 years, we have been affiliated with most of the nation's medical schools. So that means we've got about 120,000 odd medical residents rotating through our system, and about 70% of practicing docs in this country had some of their training in a VA. We also have pharmacists in training, nurses, occupational therapy, physical therapy, social work, the list goes on and on. So we actually have a real opportunity not only to get it right for the veterans now, but to imprint on these trainees what right looks like and how they can be part of the solutions. A very big part of our solution is clinical pharmacy specialists, or CPSs. You know, in government we have to have acronyms. We have, I want to say, about 9,100 clinical pharmacy specialists in our health system, and they make a huge, huge difference. So I wanted to give you a couple of examples about this. There are two areas where I can point easily to why clinical pharmacy specialists are so important. First is that primary care for us is a patient-centered medical home model, but we call it patient-aligned care teams, or PACs. By policy, every 3 teams has to be connected to one clinical pharmacy specialist. So access is a challenge for us on a lot of fronts. Some of it has to do with keeping up with where veterans are moving. That's a challenge. Some of it has to do with the fact that 1/3 of our people live in fairly remote areas. And some of it is just we've got people with a lot of medical and other challenges. as part of our effort to surface and scale and spread best practices in our system, we call diffusion of excellence. We learned that in Madison, Wisconsin, one of our clinical pharmacy specialists actually had done the work to show that you could reduce the burden on primary care physicians by about 27% if you were working closely and collaborating with a clinical pharmacy specialist. By the way, this has been available through Medicaid, to the best of my knowledge, for a number of years as a potential demonstration or waiver opportunity. I think it's fair to say, at least as far as I'm current, that uptake has been less than briskly enthusiastic. But that's going to have to be one of the policy challenges to actually figure that out. So being able to see more patients and, frankly, have people in the hands of those who know the most about the medications has been a huge boon to us. On the quality front, close collaboration with clinical pharmacy specialists has meant that in some cohorts we've been able to work with veterans to reduce the mean hemoglobin A1C, that kind of overall report card number for diabetes, from about 10 to 7.5. That is a very big deal. And in another example, we looked at chronic obstructive lung disease, often associated with hospital admissions. And through very close collaboration with pharmacy colleagues, we were able to reduce the readmission rate over the following year to 0. No readmissions, which, you know, no matter how you cut it for access and quality, is a very, very big deal. I do want to point out that several of my colleagues are here. I think the VA caucus is right back there, so I hope that those of you who will be around later today is a big deal. The one other thing I would just say, and this is a very big part of getting medications right, is opioids. It is our pharmacy team that actually led what we call the Opioid Safety Initiative. Now, obviously, they couldn't do this in isolation, very much a team sport, but we have seen dramatic reductions in the use of opioids for people with chronic pain and a variety of conditions. A lot of that, to be fair, is also boosted by using complementary and integrative health interventions for pain management. But the pharmacists have been absolutely essential to that. So I want to thank you again for inviting me today. And again, just emphasize this is really, really important. And I was quite struck by Greg Downing's comment that we'll look back and say, gosh, why weren't we paying attention? That future in terms of a lot of care happening in the ambulatory setting is here right now. Many, many patients do not have the opportunity yet to be part of a system where, in theory, the information is flowing seamlessly. Those are the calls I get, Dr. Poplin. Sometimes there's continuity with the primary care doc, but I think there's also a lot of telepathy that goes on between clinicians, and of course our patients assume that there's a seamless flow of information and like a real game plan, when I think it's fair to say that's not the case. Thanks.
Well, thank you, Caroline. And clearly, the VHA is also deserving of an interplanetary reputation for having achieved this really important innovation, as you described it, of clinical pharmacy specialists integrated into the care teams. So, Jerry, we're going to go to you now and tell us how Geisinger has attacked all of this.
Sure. So, for those of you who don't know Geisinger, we're a health system in Pennsylvania. We serve around 3 million patients between Pennsylvania and southern New Jersey. It's an integrated health system. 13 hospital campuses, about 50 primary care sites. We employ about 1,800 of our physicians. That's very beneficial to have them under our bucket. We have our own medical college, Geisinger Commonwealth School of Medicine. We have our own health plan, so we insure about 600,000 patients as well. The sweet spot for us is about 40% of the patients we take care of, we also insure. So that allows us to give some really high quality care, at least in that bucket. We have a genomic institute. I'm not sure if anybody's heard of our MyCode initiative. Gets a lot of attention, right? We have about, I think last count was 260,000 patients have consented to give us samples so we could do DNA sequencing on it, which we're currently doing, as we speak. I'll kind of get a little bit down to myself. So obviously I'm a pharmacist by training. I've been a pharmacist for 29 years, the last 17 of which at Geisinger, overseeing a lot of their clinical pharmacy programs. So right now my title is System Director of Ambulatory Pharmacy Programs. That's changed twice in 2 years, so by the time I get home it may be different. But basically what it is I oversee anything pharmacy related in the outpatient setting. Retail pharmacy, mail order, home infusion, specialty pharmacy, pharmacy assistance, okay? Probably more applicable to our conversation today, I also oversee our call center. We have a pharmacy call center, has around 30 pharmacists and actually 30 pharmacy techs and about 20 pharmacists. They're basically centrally located. They handle any sort of incoming medication-related message coming into primary care Geisinger, medication questions, prior authorizations, refill requests. The theory behind it is this all gets kind of funneled into them. They triage, manage, approve referrals, approve refills, et cetera. It never makes its way back to the docs. Huge physician satisfier. I would argue to say it's an even bigger nurse satisfier because these were things that were previously falling on them. And then our MTDM programs. So that's medication therapy, disease management. We also like our little abbreviations there. That's our CMM program, Complete Medication Management. It's pretty extensive, I think, nowhere near the VA, but we do have 73 clinical pharmacists across our entire system. They're all embedded in physician office buildings. So about 50 some are embedded in primary care offices. The rest are in specialty, so neurology, hematology, oncology, gastroenterology. You name the specialty, we have a pharmacist embedded with the docs, except for about 4 areas which are on my budget for this coming year. So we continue to expand. This group of pharmacists, they are all under a collaborative practice agreement, which helps to expand our scope of practice immensely. So basically, we like to think of ourselves as a mid-level practitioner that knows a lot about medicine. So what we do is we probably handle 17 to 20% of our system's diabetics are completely managed to our pharmacy team. We touch around 34,000 patients every single month through this team, so they're incredibly busy. They see a lot of patients, and I guess that's probably a high-level view. I don't want to take too much time, but I'm excited to be here as well and to be a part of this conversation.
Great. So just to round out that last point, so basically 1 out of 5 of your diabetes patients are entirely managed by pharmacists.
Yes, yes. So
what do you have results that differentiate between what the care,
yes,
what the outcomes are for those patients versus others?
So one of the things when I first got into management about 10 years ago, one of my first kind of nudges from the system was, you guys do a great job, show me. So we've been spending the last 10 years data collection, data analytics, so improved outcomes. We reduced hospitalizations and ED visits like 20%. Our A1C capture is between 2 and 2.4, just like the VA. Our quality metrics, blood pressure control, lipid control, all the different labs for diabetics, every single one of them is above usual care by primary care. Not that primary care is not doing a good job, they just don't have the time to do that. I think 80-some% of our diabetics also have blood pressure control and lipid control. So we do spend a lot of time tracking that. Our change recently is we've actually shifted a little bit from clinical tracking to actually tracking physician access, because for Geisinger, we have some areas in Pennsylvania that have some severe physician shortages, and that's kind of the area our executive leadership team has asked us to kind of fill. In fact, they actually came to us last year and said, could you add 50 pharmacists in the next 2 years? We need to fill this gap of the physicians we don't seem to be able to recruit. So that's what we've been working on now. Our most recent data, if you see one of our pharmacists for diabetes, we reduce acute visits about 40%. So in the next year to 2 years, 40% less people are showing up at their docs for an acute visit. They're now coming to see our pharmacists. And that also helps to keep them out of the hospital. And then just routine visits, around 20% reduction in routine visits.
So just again to follow up quickly, sure, what's the rate limiting step that keeps you from having all of your diabetes patients managed by with pharmacists at this point? Is it shortage of pharmacists or lack of ability to hire
Just
enough?
the fact that, so we have 45,000 type 2 diabetics at Geisinger, which rises anywhere from 300 to 500 every month. So in case you have your own health systems, you may want to check your rise in diabetes. They seem to be. So basically, we don't have enough pharmacists to see all of them. The other thing is we only want to see the highest risk. Right, so our goal is to get about 25% of those diabetics, because those are the ones we tend to think are the ones. That's where we want our pharmacist involved. They have multiple comorbidities. They've been in the hospital. The A1C is out of control. We have this nice algorithm we put together. These are the folks that should be seen, which amounts to 22 to 25% of the diabetics. If we do get those 50 pharmacists over the next 2 years, we will get to that mark. The referrals come in. We get 2,000 referrals every single month. So it's just a matter of getting the bodies to actually field the referrals.
Great, thank you. So Dan, we'll go to you now and hear how Health Partners is approaching this.
So starting off a little bit about Health Partners, we are an integrated organization in Minnesota. We serve about 1.8 million members, so in Minnesota and then our surrounding states, so North Dakota, South Dakota, Illinois, Iowa, Wisconsin, we offer coverage. Our care system serves about 1.2 million patients, and that's primarily in the Minneapolis metro area and a little bit into western Wisconsin. We have a research institute, and so you notice that those numbers are disproportionate. We have our care system, which provides care to all payers, so we're not locked into only taking care of Health Partners members, which represents challenges for us. My role, I get to play on both sides. So I am responsible for our medication therapy management program and for the health plan. So we deliver medication therapy management services and pay for it as a benefit. So I manage the network and the care that's being provided for employers and Medicare and Medicaid, doing the necessary reporting that we need to do. And then I also have responsibility for the care that is provided in our care system. So right now we have 25 pharmacists across our care system who are providing MTM services. And when I say MTM services, I mean comprehensive medication management. It's one of the things that pharmacy likes to do, is like to create lots of different things, and they mean different things depending on who you're talking to. Fortunately, we have a very strong definition of what comprehensive medication management is, and that is what I mean when I use the word MTM. I use them interchangeably. I mentioned that we offer this as a benefit for our members, and we do this. We've been doing. So we started in 2006 with the advent of Medicare Part D. We have Medicare membership, we have commercial membership, which is where the majority of the people we serve is, and Medicaid as well. And so we started offering services as a requirement in 2006. But we quickly moved along to saying, if this is beneficial for our Medicare patients, why are we not looking at doing something like this in our commercial market? And we started working with some of our larger employers to develop some pilots. In 2007, we rolled out a pilot with a large self-insured employer in our state, and we had a laboratory of patients who had diabetes, was a group that we went after. We followed them for 7 years. So it was a pilot that lasted 7 years. But it was a great laboratory for us to watch. When we started that program, 16% of the people who participated or who had diabetes had optimal control. And in the state of Minnesota, we have a program called Minnesota Community Measurement, where there's a measure, optimal diabetes control, which is essentially having their blood pressure in control, having their A1C in control, not smoking, taking aspirin if it's indicated, and being on a statin medication. So 16% at the start. At the end of the 7-year period, it was 65%. So you're talking a 4-fold increase. Now, during this time, we saw a doubling in the group that was our control group. So we still saw that the system, which was focusing on diabetes, was able to improve care, but when you added a pharmacist to the care, you had double the results of what happened when you didn't have a pharmacist involved in care. When we looked at costs, that group carved out their pharmacy benefits, so we didn't have insight into what was happening with total cost of care. But on the medical side, we saved over $1 million in reductions in hospitalizations and emergency utilization as a result of this. This is what drove us to cover MTM across our population. So we started off with Medicare and Medicaid. And by 2011, so 4 to 5 years it took for us to do this work, we started offering it across all of our fully insured and self-insured business. We've looked at the return on investment of CMM services on total cost of care, and we've repeated this yearly, essentially since 2012. And we've gotten better and better at doing it. Initially, I think we inflated our results a little bit. When we first started looking at things, we're seeing really high return on investment, $4,000, $5,000 per member that was engaged. And as we've continued to do a better job of matching and doing some other things, we feel really comfortable with what we're seeing now in the commercial population of $1,300 of savings per member per year for people that are participating in MTM services. So significant improvements. That's just the ROI. So I mentioned to you the clinical results. We see that across the board. When people are on the right medicines, they reach their health goals. When they reach their health goals, the reason that we're saving money is because they're not ending up in the hospital. They feel good. They go to work. It's a great story. And, you know, employers want their employees to be healthy. They want their employees to be able to go to work and do their work. And if they're going to pay less in healthcare and have more productive employees, I mean, how is that not a win? We see when we look at the population that we're targeting, and we're a health plan that really is commercially focused. More than 75% of our membership is commercial focused. Only about a 1% of the population in a commercial population is who we're going after. The people with complex medication needs, multiple conditions, multiple medications. That's the group that's really where the bread and butter is, and where a pharmacist can really step in and help, you know, really make those medicines right. The name of what we're doing here today. So it's been a really nice journey of growing this. We just need more health plans to get on board. So coming on the care system side, we want to deliver care in the same way to every patient that touches us. We can't have this system for this payer and this system for this payer and this system for this payer. How do you really provide reliable services when you have to provide different services to different patients based on who their insurance cover or who their insurance plan is? Makes it incredibly difficult. So you want to do the right thing, but you also have to keep the lights on. It's one of the big challenges that we face on a day-to-day basis. Real briefly, something that I want to touch on, continuity of care was brought up, and we are incredibly, we believe in that to a very strong degree. And the majority of the care that happens to our members happens in care systems outside of our Health Partners organization. So we are focused on connecting people where they're getting their care. So we've placed a lot of focus on building a network and going out to health systems and saying, you need to offer MTM services and we are going to pay you for it. We have a small fee-for-service payment. We also pay for outcome, so, which I think is incredibly important. So we tie those improvements to diabetes. We tie how well they're engaging the people who are at highest risk. And we connect them with people that they already know and trust. We're not trying to do this from the health plan to reach out and do what's necessary. And if we could get rid of our centralized services, we would in a heartbeat. We still need to grow our network, but it's really hard to grow a network when you don't have enough people paying for it. We've got this horrible catch-22. We really do need to have payment for CMM in order to really take the next steps.
Great. Well, thanks to all three of you. I think it's striking the common denominators among what you all three have described. First of all, clearly, whether it's VHA, whether it's Geisinger, whether it's Health Partners, teams. Integrated teams with pharmacists integrated into those teams. Whether they're CSPs or whatever designation, they are all integrated into the team. So that's number one. Number two, you all can demonstrate results, that patients get better, that they reach, as you said, Dan, their health goals in a better way. You've all said, in one way or another, that this is a benefit for primary care physicians. One of you used the phrase, Jerry, it was you, physician satisfier. You talked, Carolyn, about 27% reduction in primary care physician burden from the one, was that a study in Madison, Wisconsin? What was that?
Yes, and it was how she was able to persuade other facilities in our system to enthusiastically take this up. I should point out, in a system where we've got a lot of people wanting to come in, that also frees up space for new patients who don't have to wait as long.
The other striking phenomenon across all your systems is you are all in, or you talk about all of this happening in either a budgeted system, which is the VA, or risk-based environments, right, where you have incentives to use the resources as wisely as possible, because what you lose in revenue on the care side, you gain in savings on the insurance side, on the risk side. And I think that underscores a point that Liz made about the opportunities to do more and more of this in risk-based environments, whether it's Medicare Advantage, et cetera. So that is clearly, I think, Dan, part of the problem that you're pointing to, which is not everybody is operating in that kind of environment, either on the provider side, which is fee-for-service, or the payer side. Some payers, strangely enough, just aren't that motivated to save money. So what is your message, all of you, to the rest of the system that is not operating in this risk-based environment about the urgency of making this move? Dan, you said it, but I'll give you another opportunity to underscore it.
I think for pharmacy as a whole, the way the industry is moving towards vertical integration puts dispensing traditional pharmacy at great risk, but it gives us a huge opportunity to improve access to clinical pharmacy services, because when things are aligned, when pharmacy is not all about costs and how cheaply can we dispense drugs to the patient, and it's about how do we use medicines to keep people healthy, you make different decisions. And so this is really our opportunity to take advantage of where healthcare is going. The traditional Part D model of MTM and a PBM being carved out and doing that has really provided disincentive to provide high quality pharmacy services. So, and you mentioned it's one of the things that's frustrating. We're an organization that is all about value-based care, but when we get into the actual care system, we are still fee-for-service. So everything that we stand for and everywhere we're trying to go is value-based. And we certainly are doing things to keep moving in that direction, but the vast majority of what's happening is still turning out patients, doing billable services, because we've got to keep the lights on.
And a system that still has incentives, regardless of whatever penalties are induced, to get people into the hospital.
Absolutely.
Okay, Jerry, your perspective on that.
Yeah, I'd kind of feed off that whole fee-for-service, right? So, I could throw a bunch of numbers out there, right? But we have outcomes in virtually every specialty and primary care site we have, and they're all very promising. And our leadership, we're very fortunate that the leadership of Geisinger sees the value in it. We're fortunate we have our own health plan, so we could actually show that total cost of care reduction, right? I'm going to be spending this much on pharmacy, but I will show you people that we ensure that pharmacy is not involved in, people that we ensure that they aren't. And we're able to show that. Not every health system has that advantage, right? But even having that advantage, every budget year, how much gray hair do you think I get? Because I still have to go and I still have to kind of, put in front of them a value statement of why do we have 73 pharmacists doing patient care. As you can imagine, it's a pretty decent sized red line on the books. So an advanced reimbursement structure would probably make things a lot easier. But it's also just getting folks to understand that they shouldn't be looking at this part, they need to look at that part. The end game. We're making these people healthier. The total cost of care is going to be lower. Yes, you may spend money up front on pharmacists. Oh, by the way, I'm probably going to actually give them more expensive meds, right? So, so you may see the prescription costs go up a little bit, right? Diabetes management, anybody does diabetes management, most people should be on 2 new drugs. They're also extremely more expensive than the older remedies. But oh, by the way, I'm going to prevent them from having a heart attack and prevent them from being admitted with a heart failure exacerbation. So you know what? Take it on the chin now, but 3 to 5 years, I'm going to save you money. And that's sometimes hard for people to understand. It's hard for insurers to understand when maybe the people they're insuring today aren't going to be there 3 to 5 years from now. We've also been somewhat lucky with Geisinger that most of our patients tend to stay with us. If they sign up with us, they're usually with us for the next 8 to 10 years, if not forever, which then makes it easier for us to have that argument. So I guess I would say the challenge is just getting the culture of not necessarily looking at the money in, money out, but looking at the total cost of care, the clinical outcomes. And I think that
And
physician...
over more than a one-year period.
Yeah, and for a more than a one-year period, right? It's hard to show that change there. And the huge value of physician access. I said in Kaiser we have some issues with physician access. Somebody mentioned hepatitis C, right? We actually at one point had a backlog of, I don't know, a couple thousand folks that needed to get in to see a hepatologist because they just needed to be in the scene. So what we did is we put a pharmacist, a nurse navigator in there, gave them this little mini clinical team. We went from 5 appointments with hepatology to 1. We went from an SVR rate of like 80% to 99% because of putting this team in there. Did it cost more to put an RN at how many thousand a year and a pharmacist at how many thousand a year? Yeah, but we're now seeing 4 times as many patients. We're curing almost all of them. And in the end, it saves a ton of money because you don't have people who don't get cured, have to go on treatment number 2, don't come in, and you just waste an appointment slot. So, yeah, I could probably talk for hours, so I'm just going to shut up right now.
Okay.
Because that thing's very disconcerting.
Yeah, okay, yes. Well, the onus is on us all to cover a lot of good material quickly here. Let's go to continuity of care and particularly connect that with health information technology. I think it was Greg who said he didn't think that we have the platforms now that we're going to need to have to do this right in the future, particularly as we get to novel therapies. And we'll come specifically to a question on that in a moment. But in the meantime, let's talk about the current platform, the current state of the electronic health record at the VA, at Geisinger, et cetera, at Health Partners. How much is that essential now, and how much is interoperability, to the degree that you have it, essential to doing medication comprehensive, whatever we call it, whether it's Health Partners' version of MTM or comprehensive medication management? How crucial is it now, and what are the current limitations, and what kind of investments do you think need to be made to continue to build these platforms?
Well,
Carolyn.
if I could introduce one related topic here. There's no question that our electronic record, the one we have now, not the one we're sort of about to go live with in a few weeks, because that's future tense, has been indispensable to getting this right. Now, that said, for the veterans who get some of their care from us and some outside, that's also kind of tricky. So we end up in our testing and evaluating a number of kind of wraparound systems to try to figure out how do we coordinate that care better. I think there's a lot of different ways we could get here, because I think the game changer is going to be virtual care. Now, we're way ahead of the curve again because, as you pointed out, we're budgeted. But
So telemedicine, other
yes. So
strategies.
I could imagine for our rural veterans that they're engaging with a clinical pharmacy specialist who they've never laid eyes on except on a screen.
And who might be 5, 10, 15 states away.
Exactly, exactly. We do a lot of that right now for mental health, but it's only the beginning. So the kinds of conversations we're starting to have now are about using Uber-like software to identify who's available when you need one, like right now. Care systems really excel for fairly common problems where we commonly don't do very well, because we've got the scale and sort of strategy and the data from EHRs and so forth to figure out what to do and, frankly, what's working. But there's going to be so many more opportunities. When I think about what's coming online with precision medicine, it is pretty astonishing. So I just have to salute Katie's leadership for, having this brain inspiration a few years ago and creating everyone connected with the Institute, because this is very, very important. But at the end of the day, I think what goes under the broad umbrella of MTM could take a lot of different shapes.
So, Jerry, talk about the EHR that Geisinger has had also in place for many, many years.
Yeah,
Is it adequate now to the task?
We've been lucky enough to, or depending who you ask, unlucky enough to have same EHR for 20-some years. We were one of the first people to get Epic. It's kind of a very common EHR now. It is indispensable to have all of our teams have that ability and access to the records. Ironically, a little funny story is I lead an ambulatory task force in Pennsylvania, part of our state pharmacy association, and we actually reached out to a lot of health physician leads. And one of the number one things they said is if you try to expand to provider status in PA, we're going to have a hard time approving it in the community sites unless they somehow have access to our medical records. Because I don't want them getting too much involved unless they're able to look at a kidney function, look at all the medical records. So there's a challenge if we're all looking at different records. Within Geisinger, we have a great continuity of care because we're all on this Epic. If you notice when I said the groups I oversee, up until 4 months ago, I just oversaw call center and our MTM program. And the other 5 things were just added to me. And part of the reason they were added to me was that, well, boy, wouldn't it be nice if our retail pharmacists are talking to our clinical pharmacists, who are talking to our home infusion pharmacists, who are all under the same umbrella, and we could really connect the dots with that coordination of care. How about I have a pharmacist in neurology? How great would it be if that person was connected to my specialty pharmacist in my specialty pharmacy, and they become this little mini core clinical team? So the continuity of care, the coordination of care, and having an EHR that everybody has access to is pretty important, and the functionality of that EHR too. Epic has been great. I mean, their upgrades over the years have been pretty impressive. We just took on their genomic model to help us with our genomic approach, and that's been very beneficial as well.
But Jerry, just to underscore a point, I think you all started in the outpatient area first with Epic, and then
and
moved
quickly
to the
went into
hospital.
that.
Yeah.
And so this is definitely something that I think is really important, and I think is an opportunity for pharmacy, and it's a problem that pharmacists in the community are not trying to solve because there's not an economic reason for them to try and solve it today. So something that we are doing at Health Partners right now, we have health system-based MTM providers who provide care in our network, and we have community pharmacists who provide care in our network. And we definitely see a difference in what happens in those settings, and much of it is because the community pharmacists don't have access to the record.
They do not.
They do not. And so we're currently in a grant with NACDS and the University of North Carolina Eshelman Institute.
National Association of Chain Drug Stores.
Sorry about that. And we're working with our community pharmacists, and one of the big pieces that we're working on is how do we drive access to EHRs. And so we're going to leverage our health plan relationships that we have with the medical groups and with the pharmacies, and we're going to try and put them at the table, and we're going to try to talk about ways that we can help to solve problems. I think there are opportunities for community pharmacies to partner with health systems that don't have pharmacies, or even those that do have pharmacies. As risk-based arrangements become more and more common, community pharmacists can provide a huge amount of value to the care team. They don't get paid to do it, and we need to figure out how do we do that. Is it a relationship where they're taking some risk with the, do we as a payer contract with the health system and allow them to contract with the community pharmacy? Do we pay both the community pharmacy and the health plan or the health system? How do we make those connections? Provide some incentive for those things to touch and figure out how are they going to work together to fix these medication issues that we know exist.
So we've been talking about some of the proofs of concept that you all have developed in very common conditions, like diabetes, for example. Greg raised for us the notion of a future where we're going to have many, many more targeted therapies, particularly in areas like cancer. We have a lot of rare disease drugs now coming online, which are extremely expensive. It's going to be extremely important to get those drugs and interventions, particularly to the right patient at the right time. And gene therapy also being another set of interventions already on the landscape, but more to come. What do your systems need to do to get ready for that era? Which, as Greg suggested, we're probably going to need even more sophisticated platforms because we're also going to have to bring diagnostics into this as well to make sure we're getting those right therapies to the right patient. So Dan, let's reverse order, start with you on this one.
It's really hard. I don't think we know. I feel like we don't know what to do yet. there's a ton of conversations around how do we use this information. And right now, it's all about having that extra information. If you have more information in order to make the right decision, you always want to be in that situation. What are the valuable tests? Which person tells me the right thing? You know, different people tell me different things about different mutations. Who's right? How do we pay for it? Who do we pay for? Those are, it's a question. Every insurance company in the world is afraid to pay out too much money for things that are unnecessary, and that's where we just don't know.
And we have a wild west at the moment in terms of lab tests that are becoming available, not just
And they're
through
proprietary
conventional
to different
means,
companies,
right.
have their own.
Yeah,
Jerry?
I'm going to go and kind of probably piggyback off you. I'm not sure we've all figured it out. I mean, the number one, the elephant in the room is just sheerly the cost of some of these therapies that are going to come out, right? And how do systems and the government that's paying the bill support it? And I think we could figure that out. I think the genetic testing itself, there's some cost involved with that too, right? We get some research grants. We are able to look at some of these genetic mutations and research, and then we have to somehow then translate into clinical practice, and that does cost some money to get it verified through CLIA labs, et cetera. Once it's there, it's who is that content expert that's steering that conversation, right? Do we have that in our system? I think for genomics at Geisinger, we do. For pharmacogenomics, we're recruiting to get that person because you need that, right? We could teach people, we could put in clinician support tools in the EHR saying, hey, you may not want to do this. But they also sometimes need somebody at the other end of the phone that they could call and kind of talk it through. I think the other thing, I think we've done amazing in 3 years, we've gotten rid of a lot of noise. When I first started looking at pharmacogenomics about 3 years ago, we had a task force that I was on, and we had a couple software vendors come in and show us their systems, and they were amazing. But if you ever saw the screen, there was just so much information. And I couldn't walk away and determine what was important and what wasn't. And that was kind of our to-do with them, was go back and figure out a way to use all this in the background, but somehow give me 1 or 2 bullets that I need to address. Because I know this is all valuable information. The average doc, the average pharmacist is not going to look at 17 bar graphs and walk away with a decision. It's just going to hurt. And I think that's where we need to get to. I think we need to get to where we have that genetic information and we incorporate into machine learning models that we're currently working on. We have a couple of them in Geisinger around heart failure and stroke prevention. They're great. I don't know if we started to really pull a lot of that genetic information, but if we had it, just imagine that. Machine learning, boom, you're going to have a problem in 10 years. I need to intervene now.
Well, and it takes a system of the magnitude of Geisinger and one that has made the investment in that technology to be able to pull that off. And a lot of systems are a long way from that. What about VA and VHA, Carolyn?
So this is a very, very big opportunity for us, and I think imperative. Right now, we have 800,000 veterans who've donated or contributed their genomic information to us in something called the Million Veteran Program, and we won't stop at 1 million, but they very much regard this as a partnership. More to the point, in a more focused way, we are swimming in these waters right now because we have launched a precision oncology initiative, building on a partnership that we started about 2 years ago with the Prostate Cancer Foundation. It turns out we're probably the largest provider of cancer care in the country, and so our first initial focus is on veterans with metastatic prostate cancer who may benefit, and then we'll be adding lung cancer, and if we have sufficient volume, we'll be exploring breast cancer as well. So effectively what this means is that we're trying to create a system of excellence within this larger system. Now, that's going to bring up some interesting internal budgeting problems. Yes, we have a global budget, but how it gets allocated internally is going to be intriguing, and the initial centers of excellence for this initiative don't line up neatly to our network and other structures. I think it's all doable. I do believe that the biggest challenge we're going to have is in all of this is kind of the verb tense. What do we need to do right now and what needs to be on the drawing board? And we're not quite at the Tower of Babel phase, but we're rapidly approaching that, where everyone wants to do their piece right now. But hugely exciting because, again, we've got the scale to learn pretty rapidly what's working and what's not.
Great, great. Well, we're going to now open this up to questions and comments from those of you in the audience. Also, short speeches masquerading as questions, as long as they're very short. So let's go to a question right here. And if you would introduce yourself by name and affiliation, that would be very helpful.
Hi, my name is Larry Lamont, and I represent the California Chronic Care Coalition. And my question is really to Dan and to, well, all three of you. One of the things you said, both of you said, that those people that we cover, we have some better outcomes because of your system than those that we don't cover, who may be coming from other plans or other payers that are involved. One of the things that I'm interested in hearing more about is in terms of interoperability of data. How my understanding is that people who have this data do not play well in the sandbox with others, and that is a big problem. And I'm just kind of curious as to how do we start jump-starting that and getting so the data is available to people.
Well, I guess it starts with obviously giving everybody in the system access to this. We talked about community pharmacists not having access to EHRs. What beyond that needs to happen? All of you.
I don't know. I think it's a question that everybody is asking. So how do you provide access to the information that people need and still maintain the privacy that people desire with their information? It's this. So if I want to partner with a community pharmacy and give them access to my EHR, that's a whole lot of lawyers that are going to be talking to each other for a long time before anything is done to do that because of the risks of what happens in sharing that data. We're just in a place that we need to do more to try and figure out what the problems are, because I can't even tell you what all the problems are because we're not even trying to solve it yet.
So in a future where, assuming we have full implementation of the Office of the National Coordinators and CMS's recent rules, and we have interoperability and patients in effect can control their records and direct it by virtue of an app to where they want it to go, let's assume we get to this nirvana, will we solve the problem that way? Jerry?
To the most part, I mean, there's always some protectionism going on with people's data. So, and even in a small state like Pennsylvania, we probably have 4 or 5 maybe gigantic providers in the state, and you try to sit down and share some data and share some best practices, and some are very willing to sit down and have that conversation, and others are, they're just sitting there smiling and nodding at you, and they're not necessarily. So I think I think that's definitely a step. I think that'll be a huge help. But we also need to get folks to understand that we're not trying to necessarily use things as a competitive advantage. Like, we raise the bar for everybody if we all share and we all learn from each other. I think that's kind of the message we need to get across to people.
I think we've been chasing the wrong model, right? The idea is, my gosh, we've got all this data locked up in silos, and if we just kind of liberated that data, we'd know what to do. And this may sound painfully retro, but I mean, really the business or problem you need to solve needs to drive the IT requirements. So an app where patients know where to share their data, I'm not actually sure how instantaneously that would play in my family. Now, I want to guess about half of our veterans actually do use a personal health record, because we've had that up and running for a while. And when we migrate to Cerner, that same system will be built into it, which is terrific. But what you see, and not surprisingly, is I'd guess maybe 10% of those, boy, they are avid users. And in fact, they want all their information delivered there. And others are signed up and have some vague sense that in a pinch, someone could help them find what they need, but they're not active users at all. So I think that we've got to think a lot about the effector arm here, if you will, or the specification of why you would want this, what you would do with it, and that's pretty challenging, but hugely important.
So
And
long
I
way
can
to...
tell you, in Minnesota, almost all of our health systems are on Epic, and we have access because everyone's on Epic. You can see what's happening in all of the different health systems. So we know what it would be like if we had access to all of this information in the health system. We can see if you're a Health Partners patient and you go to a Fairview hospital, I can go look at the hospitalization without having to do all the work. It's a huge benefit. We know it's a huge benefit, but that, we're not going to tell everyone they have to use Epic. But in a sense, everyone in Minnesota has converted to Epic. I think a lot of it for that reason, because they know that they're going to be able to see what's happening, and they're better able to coordinate their care. If you know what happened in the hospitalization and you're now following up with that person and you can see what happened when you're sitting in the office with that person, it's totally different what happens as a result of that visit when you have the information right in front of you.
And apparently, since Minnesotans are nice, you have health systems that are playing well with each other also, which is making it work. All right, let's take a question in the rear.
Hi, good morning. My name is Ron Klein. I'm the Chief Medical Officer for OPM. And I was just wondering how white bagging and brown bagging affects MTM, positive, negative, or neutral. And obviously the question is not relevant for your plan members that you care for.
And you better explain white bagging and brown bagging for...
So white
the
bagging,
rest
for
of the
people that
audience.
don't know, is you fill a prescription in the pharmacy, you pick it up in the pharmacy, and you take it to your doctor, and you get the injection given at the doctor's office. I don't know. In my mind, I don't see a connection. I'm not really putting that connection together, any connection with MTM and white bagging or brown bagging. It's not something that I don't see a connection there.
So right now we're kind of knee deep in trying to figure out white bagging and brown bagging. Another thing that's going to be added to my little umbrella is something called a central medication ordering hub, and part of that is going to be a division on ordering medications out of specialty for that brown white bagging. Have a great process, and the idea is that it would be basically running through our MTM pharmacists that are embedded in specialty, that they would be the responsible party to, the doctor wanted a med, they would go through them, they would determine, is this A, our best practice, is that what we want to order, B, they'd place the order, get into a central hub that would get the pre-certs, they would be responsible for ordering, tracking, and getting it into the system. Because right now right now it's a little bit, it's a little convoluted in how the process goes, right? Some people are ordering and they're getting it from this pharmacy and it gets shipped somewhere, and then we have to try to find it and get it back into the system. There's a lack of control over did it stay cold and refrigerated the entire time before it showed up at our office. So we're gonna have a patient advocate that's responsibility is going to be to track all this, and on one end of the spectrum is going to be our pharmacist sitting in specialty, and on the other end is going to be our pharmacist at our specialty pharmacy. So we're trying to build a process around that. If you want to reach back out to me in about a year, if I'm still here, I'll be more than happy to share how we fixed it.
I hope as we move to value-based care, hopefully we won't be doing things like this. We're doing this because the pharmacy benefit pays different than the medical benefit. And so, we're creating all this extra work in order to save a couple bucks because of contracting things. And if we get to value-based care, we're going to do it the way that it makes the most sense to do it. And that's the dream.
Great. I think we have time for one more question, so can we get a microphone over to Marie in the back? Great.
Hi, Marie Brown, an internist and geriatrician outside of Rush and Chicago. We know that for every 1 hour of patient face-to-face time, there's 2 hours of documentation time in that 15 to 20-minute visit. And when I think of the vast majority of my patients who are struggling with hypertension, where we have 50% control, and when we think of the biggest impact on the planet, vaccines, clean water, and blood pressure control, and going upstream, where does medication adherence fit into CMM, MTM, and how do we get the physician, to Paul Grundy's point, that comprehensive continuity care where you develop trust so that you can uncover the non-adherence that most people are not aware of? because the first 5 times you ask a patient if they're taking their medicine, if they don't trust you and have a very long-term relationship, they will say yes. So the biggest impact, and for prevention of diabetes, when less than 85% of patients who are pre-diabetic are not even on metformin, let alone taking it, where does medication adherence and the time to develop that long-term relationship so that the patient feels comfortable telling you that they're not taking their medicine, and only then can you tailor the message to find out why they're not taking it? Where do we find the time when regulation, documentation, lack of team-based care, workforce issues are all eating up that time, and the back of the physician is what the patient sees?
So in 5 seconds or less, let's just, why don't one of you take that question, and Dan, why don't you go ahead?
CMM is made for this. This is the reason that people get better with CMM, is because it's an extremely personalized service that takes into account the value of that patient and what their desires are in medication, and finding when there are 8 choices, what's the right choice? And they make that 15 different times if they're on 15 different medicines, and they're on a regimen that they feel comfortable with and they want to take, and they know that they're going to be able to afford to take it. So it's one of the things that I think we see all the time. There's all this focus on adherence, and adherence is the end outcome, but in the vast majority of cases, the reason that they're non-adherent is because of, it's not because they don't know how to take their medicine or because they can't. It's because it causes a side effect, or someone told them something that scared them, or it's too expensive, or take your pick. And CMM figures out what those problems are and addresses them and solves them. I think it's for the group that is complicated. It's why CMM is so important.
And they have longer appointments, 30, 45 minutes to sit down versus the doc has 20 minutes to, wait for the nurse to room, and then the doc has to get in and out. So, hopefully your CMM or MTM pharmacist have some time to sit down and have that conversation. And it is about building trust. They'll tell you 5 times in a row they're taking their meds, and you have it in your Epic. It actually shows you their NPR rate is like 50%, and you'll show it to them, and they're, nope, I'm taking it. And you'll call the pharmacy, and they're not taking it. And it's about developing trust, and you will. If they see them enough, you develop trust. I haven't been in practice in 10 years, and I'll extend this real quick. But my main office is above where my clinic used to be. I still once a week will walk downstairs and run into one of my patients. Dr. Jerry, oh my gosh, my diabetes sucks. You need to come back. And that's the trust you develop, that hopefully then they share that stuff with you.
Well, we've reached, unfortunately, the end of our time. I think Greg invoked a saying that there's never been a better time to be an innovator in healthcare, and that surely is true. However, that doesn't mean it's easy to be an innovator in healthcare. And what you all have described over the last little while is the accumulation of a lot of very difficult, important, thoughtful, and expensive work. And clearly, an agenda for the nation to continue to expand the good work all of you have done and bring it to everybody. So join me in thanking this panel for a terrific discussion.
So that concludes our event today. Again, special thanks to Susan, Carolyn, and Dan, and Jerry. I want to particularly also thank Greg and Liz for their remarks. I want to thank the GTMRX organization, the Institute, and Katie, a terrific partnership with all of you today. I want to thank a couple of our BPC staff, Corrine King, Collier Fernikes, Joanne Donnellan. And I really want to thank everyone in the audience today, those who are joining via webcast. This is a critical issue. I think Paul, early on in his question, really articulated it well in terms of where we want to go, where we are, and where we want to go. And he mentioned health information exchange. We talked a lot about that today. He talked about payment reform. But it was really the third aspect, this aspect of culture. And Jerry talked about trust that is absolutely so critical. Probably the most important word in the title of today's event is team, and we have to transform healthcare into team-based care, and public policies that support team-based care, I think, are critical ones. I know here at BPC, we're going to be continuing to focus on. So thank you, everybody. Thanks for your leadership. We'll talk to you soon. Thank you.